Hi everyone, welcome to our module on platelet disorders. Before beginning with the video, I'd like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everybody. If you find it useful and wish to support its development, you can pay us with the link that's on the screen and that's also been in the description. You can pay us with any of these payment methods. Now let's begin with briefly understanding the different kinds of platelet disorders and what a platelet disorder is. Platelet disorders typically present with mucocutaneous bleeding, and this includes petechiae, purpura, epistaxis, and gingival bleeding. A very important distinction is that platelet disorders can cause superficial bleeding, whereas coagulation factor deficiencies or coagulation disorders can cause deep bleeding, like hemarthrosis. So this distinction is frequently tested in the exams. We classify platelet disorders into two main categories. The first one is the quantitative disorders, where the platelet count is decreased. So this is called as thrombocytopenia. And the other one is qualitative disorders, where the platelet count is normal, but the function is impaired. So we also need to remember that the normal platelet count is ranges between 1,50,000 to 4 lakh per microliter. Now let's try to understand and discuss about thrombocytopenia. Thrombocytopenia is defined as platelet count less than 1,50,000 per microliter. So the causes can be broadly divided into decreased production, increased destruction, and splenic sequestration. Decreased production, increased destruction, and splenic sequestration. So classically, mild thrombocytopenia may be asymptomatic, but when platelets drop below 20,000, patients can develop spontaneous bleeding. Immune thrombocytopenic purpura is an autoimmune condition. So whenever there are IgG antibodies which target the GB2B3 receptors on the platelets, so these antibody-coated platelets are then destroyed by splenic macrophages. So in response, the bone marrow increases the platelet production. So you see increased megakaryocytes, or just like whenever there's increased red blood cell production, you find a lot of quantity of reticulocytes in the bloodstream. Whenever there's increased platelet production or compensatory platelet production, we see increased megakaryocytes in the bloodstream. In children, this ITP often follows a viral infection and is usually self-limiting, whereas in adults, it tends to be chronic and associated with other autoimmune conditions like SLE or infections like HIV, hepatitis C. And the common laboratory findings in the cases of this immune thrombocytopenic purpura includes low platelets, normal prothrombin time or normal partial thromboplastin time, along with an increased bleeding time. Now let's try to discuss about thrombotic thrombocytopenic purpura or TTP. This TTP is caused by a deficiency or inhibition of a protein called as ADAMTS13. So this ADAMTS13 is nothing but a metalloprotease. So this metalloprotease function is to just cleave ultra large 1 millibrand factor multimers. So whenever there's deficiency of this ADAMTS13, there is deficiency of a protease which breaks down these multimers into fragments. So whenever there's the deficiency of this ADAMTS13, it leads to increased large 1 millibrand factor multimers. So without it, these large 1 millibrand factor multimers can just accumulate and cause excessive platelet adhesion and formation of microthrombi. The classic pentad includes fever, microangiopathic hemolytic anemia, thrombocytopenia, neurological symptoms, and renal dysfunction. So on peripheral smear, you'll be seeing cystocytes, which are nothing but fragmented red blood cells, like the characteristic cells that you're seeing on the image right now. So So these are just fragmented RBCs, and these are also called as cystocytes. So whenever you see cystocytes on a peripheral smear, you need to think about thrombotic thrombocytopenic purpura. So the classic penta that we see in a case of thrombotic thrombocytopenic purpura includes fever, microangiopathic hemolytic anemia, thrombocytopenia, neurological symptoms, and renal dysfunction. In TTP, the platelet count is low and LDH is elevated, along with a reduced haptoglobulin level. Then there's normal PT and normal APTT, and this helps us differentiate between TTP and disseminated intravascular coagulation, where they're just prolonged. Now, coming to hemolytic uremic syndrome, this hemolytic uremic syndrome is most commonly seen in children. It is caused by Shiga toxin from Escherichia coli O157H7. So this toxin just damages the endothelial cells, especially in the kidneys, and this eventually leads to microthrombi formation. The classic triad in hemolytic uremic syndrome includes microangiopathic hemolytic anemia, thrombocytopenia, acute kidney injury, and other feature that can also be seen in this hemolytic uremic syndrome is acute bloody diarrhea. So when compared with thrombotic thrombocytopenic purpura, this hemolytic uremic syndrome has more prominent renal involvement, whereas TTP has more and more neurological symptoms. Now let's try to understand about disseminated intravascular coagulation. So this DIC is a systemic activation of coagulation. The key concept is that both the clotting and bleeding occurs simultaneously. Both clotting and bleeding occur simultaneously whenever there's mention of DIC. So the clotting factors and platelets are consumed, which leads to bleeding. So you can also describe it as typically as a case of consumptive coagulopathy. So whenever there's simultaneous clotting and bleeding, what eventually happens is more and more clotting factors are consumed in this process. More and more platelets are consumed in this process, and this eventually leads to consumptive coagulopathy. Okay, so coagulation along with consumption of the clotting factors. So this is called as consumptive coagulopathy, and this is typically seen in case of acute disseminated intravascular coagulation. And this consumptive coagulopathy eventually leads to bleeding. Common causes of DIC includes sepsis, which is the most common cause, then trauma, then obstetric complications like abruptio placenta, and malignancies, especially acute promyelocytic leukemias, are common causes of DIC. So we can memorize the causes of this disseminated intravascular coagulation using the mnemonic stop making new thrombi. So S stands for sepsis, T stands for trauma, O stands for obstetric causes, P stands for pancreatitis, and making stands for malignancies like APL. The classic lab pattern is in any case of DIC, there's prolonged PT and prolonged APTT, and then there's increased bleeding time, decreased fibrinogen, and increased D dimer. So this increased PT, increased APTT. So these things, these happen because of consumption of coagulation factors, where we just have deficiency of coagulation factors like factor 7, factor 8, factor 2, factor 5, whatever it could be. So whenever there's more and more coagulation factors being consumed, this leads to consumptive coagulopathy, and this in turn leads to prolonged prothrombin time and prolonged partial thromboplastin time. And whenever there's consumptive coagulopathy, there are more and more platelets being consumed, uh, and less platelets being available in the bloodstream. So this can lead to increased bleeding time. And as a result of more and more clots being formed and more clots being that the clots that are formed being broken down, this can lead to increased fibrillation products in the uh, form of increased D dimer. So this reflects consumption of clotting factors and increased fibrinolysis. So on peripheral smear, you'll see cystocytes again. So cystocytes, as I've discussed in the previous module, so it's nothing but fragmented RBCs. So whenever you see peripheral smear with this fragmented RBCs, you need to understand that they can be cystocytes. So the cystocytes are characteristically seen in cases of disseminated intravascular coagulation. Clinically, these patients can present with bleeding from multiple sites like gums and intravenous sites and also cannulations. And they can also present with organ ischemia due to microthrombi, and severe cases can even lead to shock. So now let's try to understand the high yield comparison between thrombotic, thrombocytopenic, purpura, hemolytic uremic syndrome, and disseminated intravascular coagulation. This TTP has ADAM TS13 deficiency. ADAM TS13 is nothing but a metalloprotease that is needed for breaking down the uh, large von Willebrand factor molecules into fragments. So whenever there's Adam 13 deficiency, there's more and more availability of increased large von Willebrand factors, and this leads to more and more adhesion, and this in turn leads to coagulation. So the common features that are seen in TTP includes neural symptoms alongside the classic triad that we have discussed about, the classic triad of thrombocytopenia, renal dysfunction, and microangiopathic hemolytic anemia. In addition to these three, in addition to this classic triad, we can also see neurological symptoms and fever. And this TTP, we need to understand and memorize this. Most importantly, PT and PTT are normal in a case of TTP, whereas hemolytic uremic syndrome, this is due to Shiga toxin with renal involvement and with normal PT or PTT. So again, PT and PTT is normal again at the level of the hemolytic uremic syndrome. So, disseminated intravascular coagulation has systemic coagulation with prolonged PTT and PTT, prolonged PT and PTT, and both bleeding and thrombosis. So, this differentiation between uh, how the PT levels or how the APTT levels or how the bleeding time change between different kinds of disorders. So, these are highly tested on any kinds of examinations, and we just need to memorize them. Not just memorizing. When you try to understand the concept by just sitting down in front of a book and you're reading your book with your mind open, you can just clearly understand the mechanism of how it happens and why it happens. In qualitative platelet disorders, platelet count is normal but function is impaired. So in these cases, bleeding time is prolonged. So clinically, these patients also present with mucocutaneous bleeding. Now let's try to discuss about a syndrome called as Bernard-Sollier syndrome. So this is a kind of a functional platelet disorder. There's a defect in GP1B which leads to GP1B deficiency. This GP1B is responsible for platelet adhesion to the von Willebrand factor. We have discussed this many times in the previous module. So this GP1B is concerned with platelet adhesion to the von Willebrand factor. So the problem here is defective adhesion. So whenever there's deficiency of GP1B, there is defective adhesion happening, and this is a classic feature of Bernard-Sollier syndrome. There's defective adhesion, and the other key feature in Bernard-Sollier syndrome is the presence of giant platelets. There's giant platelets, and thrombocytopenia may be present. The other functional disorder is Glanzmann thrombasthenia. In this disorder, there's defect or deficiency of GP2B3A receptor, and this GP2B3A receptor is concerned with platelet aggregation, binding binding different number of platelets with one with each other, along with a fibrinogen network. So there's a defect in this GP2B3A receptor, and there's defective platelet aggregation. So this distinction between adhesion and aggregation is really important. Bernard-Sollier syndrome is a defect with the adhesion, concerned with the GP1B receptor, Whereas Glanzmann thrombasthenia is a problem that is concerned with the aggregation of platelets, and the receptor that's involved is GP2B3A receptor. In uremia, toxins impair both platelet adhesion and aggregation. So this is seen in chronic kidney disease cases. Aspirin irreversibly inhibits cyclooxygenase 1, or reducing thromboxane A2. So this decreases platelet activation, and the effect lasts for entire lifespan of the platelet. So coming to heparin-induced thrombocytopenia. So this heparin-induced thrombocytopenia is extremely high yield. It is caused by antibodies against the heparin platelet factor 4 complex, heparin PF4 complex. So this leads to platelet activation, causing paradoxical thrombosis despite low platelet count. So it typically occurs 5 to 10 days after heparin exposure. Management is to stop heparin and start an alternative anticoagulant like argatroban. Now let's just try to quickly revise the entire module. ITP is autoimmune with uh, GB2B3A receptor autoantibodies. This is associated with splenic destruction, increased megakaryocytes, and the typical feature is that the PT and PTT are normal. In in thrombotic thrombocytopenic purpura, so there's a deficiency of this Adam TS13, and this leads to microangiopathic hemolytic anemia and thrombocytopenia along with neurological symptoms, fever, and renal dysfunction. Now again, so this is the key feature that's highly tested on any kinds of exams. This PT and PTT are normal again at TTP also. While coming to hemolytic uremic syndrome, so this is typically due to Shiga toxin as cholesterol O157H7 as we have discussed. So in this case, renal failure is predominant, and again, PT or PTT is normal. Now coming to disseminated intravascular coagulation, this involves systemic coagulation. There is increased PT and PTT. There is reduced fibrinogen. There is increased D-dimer, and this is associated with bleeding and thrombosis at the same time. There's bleeding and coagulation happening at the same time. In the case of disseminated intravascular coagulation, this DIC can present with consumptive coagulopathy, where just there's depletion of the all the kinds of clotting factors, which leads to bleeding. Heparin-induced thrombocytopenia, or HIT, involves anti-platelet factor 4 antibodies, and this can cause thrombosis. And this occurs 5 to 10 days after heparin usage. Well, let's go through the key exam traps on the USMLE. So, platelet disorders cause mucocutaneous bleeding. So, whereas coagulation disorders cause deep bleeding like hemarthrosis, as we have already discussed. TTP and HUS have normal PT and PTT, while DIC has prolonged PT and prolonged PTT. Cystocytes are seen in TTP, hemolytic uremic syndrome, and disseminated intravascular coagulation. Cystocytes are not just characteristic for DIC, so they're also seen in cases of TTP and HUS. HIT causes thrombosis, not bleeding. So heparin-induced thrombocytopenia causes thrombosis, not bleeding. Aspirin effects last for the entire lifespan of the platelet for about 7 to 10 days. So aspirin effect lasts for about the entire lifespan of a platelet for about 7 to 10 days. And finally, also remember that Bernard-Sollier syndrome is associated with the defect with the adhesion of the platelets, and the receptor mainly involved is GP1B, whereas in Glanzmann thrombasthenia, so it's concerned with an aggregation defect, and the defective receptor is GP2B3A receptor. Thanks for watching the video. Before ending the video, I'd like to request all of you to subscribe and keep supporting. I'll be right back with another video in the same hematology series. Thank you so much. Bye.